and really talk about why do we care about injuries. If I was to ask everyone sort of live, how many people have been injured, how many people thought it sort of sucked, it's probably most of the people in the room, particularly for me when I'm talking to a very sports science group of students. But also sports injuries are a big issue. So in Australia, so this is just Australian data, in 2016, 2017, there were almost 60,000 hospitalizations due to sports participation. This is not going out and rolling your ankle, treating yourself with Ricer. This is going to hospital, ending up in the ED and having further treatment from there. So it's not a cheap sort of injury to manage, hospitalizations, and in today's environment, we don't really want to be ending up in hospital. So with when we look at that, most of these come from the football codes, netball and basketball, so our team sports. And the football codes, Australian football, which is our sort of native code here, the two rugby, so rugby league and rugby union, and association football or soccer. Netball, for those who aren't from a Commonwealth country, it's definitely going and worth having a look at a netball game, because if you were to design a game where people were to get injured, it would be netball. What's really good for us from an injury prevention point of view is that a large proportion of these injuries are due to non-contact mechanisms, which means that we can actually intervene at the level of the athlete or without having to change too much and actually come up with some sort of positive outcome, positive mechanism. We don't have to change the game. We don't have to do anything like that. We can intervene and change the athlete and change how they interact with their environment. So when it comes to injury, it's really all about the load and the load that we experience. And, when we get injury, we have the load which is too big. We have a load which is in the wrong direction. We have inadequate support, or we have inadequate loading frequency. We're either loading too much, so we get our overuse injuries, or we're loading too low and quickly transition to a high frequency load. And that's a lot of where our workload management comes in. So really, the interaction of these four factors are what leads us to getting injury. In the end, a tissue is going to get damaged when the loads that you apply is too big for the tissue's ability to cope. So you get your elastic band, you stretch it, it's all good, and then it breaks. The same with any of our tissue body structures as we go through. So if we look at injury prevention, there's lots of models out there around injury prevention. Van Melton. The one that I really like is the one proposed by Carolyn Finch in 2006, which takes injury prevention right through from our initial phases through to actually getting people to do the injury prevention. So if we look at that, the first step is obviously to look at what injuries are actually out there. So who's getting injured, how many people are getting injured, and that becomes a sort of a big thing. If there's one person who gets injured and no one else in the sport ever has through that mechanism, trying to prevent it is probably fraught with we're doing a lot for not much bang. If we have a injury which doesn't have huge detrimental outcomes, for instance, say a hamstring, for most hamstrings, but that happens a lot, we want to intervene there. Or something like an ACL, which is what we're going to talk about through most of this lecture, so the anterior cruciate ligament, happens relatively regularly, but when it does happen, it usually leads to about 12 months out of sport, which, for the Joe Blow athlete or even a professional athlete is not something we want. So once we know what injuries are actually occurring, we want to intervene. And to intervene, we first need to establish how the injuries are actually occurring. So look at where the injuries are occurring and also look at the mechanism of injury. So once then we get a good handle of that, we can go through and work out what our intervention looks like, do our programming if we're from an exercise science background. Then we should be testing it out in an ideal conditions. Everything's perfect. We're nice, controlled, experimental environment. And once we know there and it works, we can go out and we can say, how do I get this from my lab to everyone in the country doing it? And then finally, we need to go back and evaluate. So where does biomechanics come in? So it really sits through steps 2, 3, and 4. We're not epidemiologists. We're not going to go out and do the surveillance. Most of us are not going to be doing the implementation phase, but we're really about understanding how we're getting injured, developing prevention measures from that, and then going through and doing the evaluation. So if we work through all of these, and this is the work that came out of my PhD, looking at how each of these steps work. So the first step is really to look at how are we getting injured. So look away now if you don't like gory videos, but this is an example of a contact ACL injury. So if you watch the guy coming across here, just turn a pointer on. If you watch this knee here, he gets hit, he gets into that knee abduction, rotation, and ACL is gone. And from a intervention point of view, there's not much we can do about that. He's being crushed into with his knee. It's a completely legal environment within that sport, so there's not much we can do without really changing the way that the sport is played. The next sort of injury is an indirect contact. So we can see that he's had his loading environment changed by this player here, and then we've had this injury occur here on his left knee. And again, there's only so much we can do to manage and to intervene in these sports. And finally, we now move to our classic ACL. So if you watch this player here from Essendon, if you watch this left knee, sorry, Essendon, I forgot I'm not speaking to just Australians, Essendon's the team in black and red. We can see that as the player comes in, he throws his leg out and his knee collapses in. Now, one thing to note when he actually gets injured is that you can see that he's placed his foot a long way from the midline of his body, and he's leaning his torso back over this support leg. And we'll see that same position if we look at other ACL injuries. So this is where England lost their 2006 FIFA World Cup bid when Michael Owen snapped his ACL. I do apologise for anyone in Europe or anyone in England who's watching this. But again, as we see, he goes to suddenly change direction, throws his leg out a long way, and we can see it collapsing down and in. So again, at foot contact, his foot's a long way away from the midline of his body. And here's a more recent one from AFL, the women's AFL. If you watch his left knee here, we can see that as he goes to change direction, the knee, again, a long way away from the body, torso is coming back over there, and we see it collapse back in towards the middle of the body. So before we go on to the next step, just a quick recap, depending on where you are in your particular course, as to what a moment or the moment of force or torque, we use these terms interchangeably. I think much of the exercise science or sports area talks about it being the moment, which is really the turning effect of a force, not a moment. I do apologize with my typo there of my words. And the important thing to remember is how do we calculate our moment, or the two components of our moment is the force and our moment arm. And the moment arm being that perpendicular distance from our axis of rotation to our line of action of the force. So very quickly, we've got this here. So we know that these two characters here will balance out that seesaw because they each produce the same bending moment, because we've got the same value here. This one is double the force and half the moment arm of the other athlete, or the other angel there. So we're going to have a balance out. So that's what we're talking about when we're talking about moments here, is that bending force that's occurring. So if we look at our ACL, we've just seen people go through and get injured. And when they get injured, we saw that we had the knee tends to collapse in, which is what we call a valgus load or an abduction load of the knee. And this is some cadaveric work where we can go through, and they went through and they actually loaded the ACL. This work by Markov in 1995. And they loaded the knee with an anterior drawer load. So this is this black line coming through here, where we pulled on the quadriceps tendon, which slightly pulls the tibia forward, which causes an anterior drawer load on the ACL. What these other lines here is the combination and the addition of an additional load. So we can see here that below about 10 degrees of knee flexion, we get a huge increase in the load on the ACL when we apply an internal rotation load. Again, with our varus load, so this is when our ankle is pulled in, so we're putting a varus moment or an adduction moment on, we can see that we see an increase in our anterior or ACL load, again, below about 10 degrees of knee flexion. If we look at our valgus load, from about 10 degrees of knee flexion through to, right through, we see an increase in our anterior draw. So if we apply this valgus load, we really see an increase in the load on the ACL. And really the big loads are these valgus and internal rotation. These are the ones that have been shown to be dangerous when we look at this cadaveric work, and they're the lines to where we see the knee collapse. So when we looked at all of those, we saw the knee collapse inwards and down. What we also know is that the ACL can be supported by the muscles that cross the knee. So all of the muscles that cross the knee, we talk about our quadriceps as being extensors, but if you think about our quadriceps, if we break them down to our vastus lateralis, it actually inserts on the lateral aspect of the patella. So it's going to have a lateral force. It will produce an abduction moment on the knee. Similar with our vastus medialis, inserts onto the medial aspect of the patella. So it's going to produce a varus moment on the knee. So if I contract all of my medial muscles, I'm actually going to counter out an external valgus load, so something which is forcing me into a valgus position. So our muscles, yes, our quadriceps are extensors, our hamstrings and flexors, but they also have the ability, because of where their tendons insert relative to the axis of rotation, which is going to create that moment, they can produce varus and valgus and internal and external rotation moments, and which allows them to support. And we can look at that through our total activation, how much muscles are occurring, their co-contraction, and also our muscle strength can interplay with those. So we've gone through, we've seen how people get injured, we've looked at the loading, and now we can think about, well, why do we think that that might be a bad position? So we saw that when people got injured, they tended to look like this, with a wide foot placement a long way away from the midline. So we remember back to our moment, it was our force, and in this case, we can assume our force is our mass multiplied by gravity coming down through here. So in both of these athletes, it's the same mass, it's the same person, but we can see that we have a different moment arm. When our foot's in close, we have a small moment arm, so the force is coming down not too far away from the medial aspect of the knee. And on this one, we have a much larger moment arm. So what that results in is a much bigger abduction or a valgus moment in this wide foot placement.